Но, в принципе, аудитория нас уже слышит, да?
Да.
Окей.
Можем начинать тогда, да.
Ну да, можно, так сказать, подогреть немножко аудиторию. Коллеги, здравствуйте, видите?
Dear
Вот,
colleagues, good afternoon. At the bottom of the screen, you can see the tools available during this workshop. You can see the raised hand option. You can also use smiles and other symbols for your comments. You also have the option of interpretation, and you can choose the right language. Also, you can see the members of our panel. Diana, good afternoon. We'll wait for a couple more minutes and then we'll start. We see that our participants continue to join us, and this is very good. The organization committee informed us that about 120 people registered for participation in our workshop, and we'll make sure that the recording of this event becomes available after the workshop.
Понемножечку заполняется аудитория, у нас уже 40
We see that
участников.
40 participants joined our webinar.
И да, пожалуйста, используйте чат для того, чтобы вести коммуникацию либо со всеми.
Please use the chat to communicate with your colleagues, with our presenters. And also, please note that we have a special module for specific question and answers, and we will try to use it as well. Liliana, we are approaching to the start of our webinar. And I believe we can start. The floor is yours, Liliana. Thank you very much, Andrei. Dear colleagues, dear friends, I'm glad to welcome you on behalf of the PASS Center and to send the best greetings to all of you from our portfolio manager, Alexei Bodrik. Unfortunately, he is hospitalized now and he will not be able to join us. However, he's with us in spirit, and I think you will all agree that we need to send him our best wishes of quick recovery. I would like to say that patient-centered care is the key element of the WHO strategy to end tuberculosis, and it is also the basis of the TB-REP program. As you know, the countries of our region are at different stages of the transformation of their TB care delivery and approaches to TB care delivery at different levels of the healthcare system, including at the primary healthcare. It is very important to ensure availability and accessibility of TB services exactly where people need it. It is also very important to make sure that our healthcare systems allow TB patients to move freely along the entire pathway and continuum of care. So today, during the webinar, we'll talk about the tools that can be used during the patient's pathway and how we can identify the problems during this pathway and how we can better provide the necessary support and assistance to the patients. We'll also share the global practice of the analysis of patients' pathway. We'll share the data available that could be used for planning and designing of the TB control programs. We'll also share lessons learned in the implementation of the data obtained during the analysis implemented in our region. And we'll talk about the use of this data at the national and regional levels. As Andrei has already mentioned, you have different options for sharing your comments and questions. Please use the chat and please use the survey. We're going to use two of them. We'll have two questionnaires at the beginning and at the end. And of course, we also have another option for discussion of various questions is the Q&A session during our webinar. I would like to wish all of you to have a very fruitful webinar. And now I would like to give the floor to Andrei Dadu, representative of the WHO Euro. Andrei, the floor is yours. Well, something is wrong with my camera. I'll try to fix it later. But I would like to thank Liliana for your introduction. This webinar is very important, especially considering the fact that the reforms that were initiated quite long ago and the change in paradigm of care delivery and TB service delivery that was initiated several years ago. The need for it became obvious quite long ago, and I'm very glad that today we will have an opportunity to present the first for our region experience. In this analysis, we'll share lessons learned and we'll make all the information available to all of you today. On behalf of the World Health Organization and WHO Regional Office for Europe, and on behalf of Dr. Askal Didilbayev, I would like to welcome all of you at this workshop, and I would like to thank you for participation in this webinar. You will have a chance to get acquainted with the recommendations used for the analysis of various approaches used in the countries and about the adaptation of these approaches to the new concept of patient-centered approach. Also, I would like to remind you that the materials of our webinar will be made public. We will share the links to the presentations that you will see today. And also, we are going to share the recording of our webinar so that sometime in the future you could have a chance to review the information of our webinar and to get back to the examples of the lessons learned by our participants. Hopefully, you will be able to use this information later on in your practice, in your relevant projects. Liliana, do you have any other additional comments about the agenda of the webinar? After the presentation of NOBU, we'll have a focus group dedicated to the regional experience. And the focus group on the use of our tools and the country experience. So I believe that this section of our webinar will be very useful because our participants will have an opportunity to find more about the use of these tools. So I am anxiously waiting for this new component. The agenda is very interesting, but before we introduce our colleague from Geneva, I would like to say that Nobu Mishiroki works in the global TB control program at our headquarters in Geneva. He will make a very interesting presentation about the tools that were designed for our programs and that are the main recommendations for analysis and adaptation of services to make them patient-centered. But before that, we would like to ask you, Nobu, what do you know about the tools that we designed? Liliana, Christina, we expect to offer the survey, a brief survey for you. And you can see it now. We need to understand what to start our webinar with. And so we need to know what kind of knowledge you have about the tools and materials available. So we kindly ask you to answer the questions of the survey. So question number one, are you aware of the documents presented in the survey? And if you scroll down, you will see the questions related to the use of collect information for the background of your planning activities. If you are familiar with the documents, select the answer yes, and you should be able to see the questions of the survey on your screen. As I can see, you are familiar with these documents, which is very good. Unfortunately, I don't see the results. Oh, here they are. We have only 13 answers. Nevertheless, we see that about three-fourths of the participants are familiar with the tools available for the design of patient-centered approaches. So you are familiar with the people-centered framework for tuberculosis program planning and prioritization, and you're also familiar with compendium of data and evidence-related tools for use in TB planning. Thank you very much for your answers. 13 participants gave answers to our question. And now I would like to start the next session. As I have already said, we invited Nobu Nishiroki to make a presentation. Dr. Nobu, I'm very glad that you agreed to take part in our webinar and to make a presentation on the tools that were mentioned in our survey. Once again, I would like to say that Nobu is the focal point for PPA and PCC. He was also the facilitator of the team that designed these tools. Nobu, the floor is yours.
I think you should unmute your microphone, Nobu.
Okay, sorry. Yeah, thank you very much. Thank you for this great opportunity to be part of this very important webinar. So I'm requested to present how we see the way for analyzing the information so that we can organize the TB care in the more TB-centered manner. So I'm going to use this presentation, and then I'm glad that this presentation will be kind of setting the scene for this very important initiative, people-centered patient pathway analysis conducted for all the countries. So let me start. So maybe before putting my presentation, I'd like to pose a couple of questions, because this is actually outlining the importance of these activities. So why we need to change our perspective in organizing TB care? What is the bottom line issue we have? Are our services, TB services, people-centered, or we still have much more provider-centric services? Or why TB services not accessible by many people yet? And why we continue to generate drug-resistant TB in many countries? Why people with TB facing catastrophic costs? So I think these 4 questions are very critical key questions when we are reviewing our TB program and services. Why? Oh, sorry, I continue getting this pause. Okay. Because I think the overall, of course, the goal for the health sector, goal for the SDG under the SDG is universal health coverage. This universal health coverage envisions all people have access to good quality health services without people experiencing the financial hardship because they must pay for care. So this definition of UHC has very important keywords, right? Which is access, quality, and financial hardship, right? So universal health coverage need to fulfill these 3 key criteria or key properties. But how we see our TB program at this moment? Access. Our TB services accessible by all people with TB, or all people need our services? Maybe not, because we know a lot of issues around the missing people with TB. We are not detecting or providing the proper diagnosis for all people who need them, right? Quality. Our TB services in good quality so that we can declare that we are universal health coverage in TB services. Not, we are continue generating drug-resistant TB. Our quality of care is all about continue providing the substandard care, or for some reason, patient cannot really receive full course of the quality treatment so that it can generate drug resistance, right? Financial protection. Of course, this is one of the NTB strategy indicator. We want to eliminate catastrophic costs due to TB because we know many people still suffering financial hardship, right? Just accessing to TB care or staying in TB care. Is that really not acceptable? Because we are treating TB patients, diagnosing and treating TB patients, but at the end of our treatment, patients become poorer, right? Family becoming more difficult financial situation sometimes because of the receiving TB services or just going through TB experience and the stigma discrimination associated with that. So actually, in terms of the achievement in the universal health coverage, in the even limiting to the TB domain, our services are not fulfilling this universal health coverage criteria. So that's really the important bottom line. So how we can address this and why this is the case, right? So we think that, in order to improve this situation, it is very important that we can review our TB services and also situation of the patients and also our readiness of our program, whether we are organizing services around the patient's need or people's need, right? In terms of the looking at the data and the evidence, we have so many information available now, right? We have so many tools like epidemiological review, prevalence survey, surveillance information, drug resistance survey, different approaches and analysis like GIS or modeling study, inventory study. There are so many information available, but are we really effectively using these different information to properly analyze our situation, right, of our services and also the situation of the patients or people? So our problem statement here is we have so many information available now compared to maybe 10 years, 20 years ago. We still have, we are not effectively using this information in improve our TB services. Maybe not enough. Maybe some parts we are already rich in the data and then rich in response, but maybe not enough. So our idea is probably let's look at our information to review the situation from the people perspective, not from the epidemiologist perspective or not from the healthcare provider perspective. From the patient perspective or people's perspective, we can review the data again so that we can understand better what is the issue, why we have this issue in the 3 domains of the universal health coverage. So this approach called the people-centered framework include 3 elements. One is we use the continuum of care to guide our data consolidation and the information analysis. Then we also use the data from the different angle, so which we call it 3 types of the evidence. One is epidemiological information, and then also people-centered evidence, and the system-related evidence. So this is basically know your epidemic, know your people, and know your system. Right? We need to understand our situation from 3 perspectives. Then we use this information, try to organize 3 steps of the thinking. One is the problem prioritization, where problem lies, and what are the cause of this problem. Then how we can change the situation, intervention, using the interventions, right? So our people-centered framework outline these 3 elements, then try to promote how to use effectively the data for improve our TB care. So I just want to explain very briefly about this approach because we don't have a good enough time for explain everything. But first, this framework element use the continuum of care. Then actually this continuum of care, we try to look at the different data information along the pathway of the patient's continuum of care. So people not accessing the health system, people with TB seeking care, but maybe not diagnosed or notified, and the people notified, but not cured, successfully treated. So we try to see the data in different stages, right? Then actually, we try to analyze this information so that we can see where is the bottleneck or what is the issues in each different stages of the patient pathway. So there are 3 main blocks here, but actually further broken down into the 3 blocks. It's 9 blocks. So we try to consolidate or extract the data, available information from different data sources to analyze the situation by this pathway. Then, as I say, we try to extract the information from an epidemiological angle, and then people-centered angle, and the system-related angle. There are examples of the different data sources, but I don't go into detail now. But in short, we have a lot of epidemiological information, right? And but sometimes we miss a lot about the people. We miss the information to understand the people, like treatment-seeking behaviors, or demographies, or risk profiles. And there are so many information, right? It's there in the different sectoral data, but TB program may not look into those information. Then last one is the system. What is our system, right? Whether our services are really sufficient to provide the services. By the way, patient pathway analysis we are going to look at after this session is actually trying to match these people's information and the system information, right? We need to see where people go, and then we need to see whether these people or these facilities people go is much equipped with the services, right? So that's actually one aspect of it, right? Within this overall framework of the three types of evidence. Then after we see this patient pathway, continuum care, and the three types of the evidence, we try to map out the information. This is just the illustration in the boxes. We try to map out this information like this way. So we are feeding the data in each stage of the patient pathway. And then we also consciously look for the data from the epi, people, and system. Yeah. So that is the way we try to consolidate the information. Then after consolidating this information from very much different wide range of the data sources, we use this data frame to stimulate or stimulate the national discussion to improve care. So maybe I don't go into the details now because it's very much information in these slides. For example, this is one snapshot of the one box, right? This is people with TB who seek health care but are not diagnosed and not notified. Then we try to take the information from the patient pathway analysis, prevalence survey, inventory study, epidemiological data, then try to feel what is the evidence of how people behave, or what is the epidemiological situation, or what is our readiness of our system. So I don't go into detail now. So like this way, we try to map out information along the continuum of care. So then by using this consolidated data, we can discuss in the form of a workshop or the workshop or in the form of the national dialogue to identify the problem and analyze the problem, the causes, and then also discuss about the intervention. So this approach of the people-centered framework can be used for different stages of the TB program planning. Like, for example, it can be used for the NSP development process as a situation assessment, or we can use it for the sub-national planning workshop, or we can also use this framework for monitor the implementation, right? By looking at the monitoring indicator mapped out along the continuum care so that we can see our regular implementation monitoring from the people continuum care perspective. And also we can use this framework as an evaluation tool. So this is really only the, kind of quick skim through of the approach. But I think, I hope that this can give a good idea what is this people-centered framework aimed at and they can do. So this people-centered framework is a way to provide a systematic way to summarize all relevant country data along the continuum care. And then also this will stimulate evidence-based discussions, right? Which lead to the evidence-driven planning. And then also can facilitate effective dialogue and discussion at country level, wide variety of stakeholders, including civil society or other important stakeholders. And also this can stimulate country-led process or local subnational bottom-up planning process. So in short, I would say that this people-centered framework is maybe you can see this is maybe just similar to the EPI review or something very similar to the usual situation assessment. But the difference here is that this framework forces you to think your data in the people perspective, right? Even we have the same information statement, like, okay, only how many patients are diagnosed in the health facility among the people who seek care. This only one statement. If we position in this continuum care, it will be immediately seen as a health system bottleneck, and then we can stimulate the discussion how to improve it. So maybe I stop here. We are going to have a more rich, even more rich discussion around the patient pathway analysis. But maybe this can hopefully set the scene for what is the overall purpose and aim of the for us to look into the data from the people perspective. Thank you very much.
Thank you very much.
Nobu-san. That's very helpful indeed. Back to you, Liliana.
Yes, thank you, Andrei. Thank you, Nobu-san, for reminding us once again how important the people-centered approach is. And we need to keep in mind that everything we do here in the region and elsewhere is around the person, first of all. Позвольте мне далее, коллеги, представить, попросить включиться.
Now, please let me ask, dear colleagues, quartet of people. Andrei used this term. It's like a four-piece band. Armen Khatak, Mikhail Volik, and two other specialists who within the last year and a half have worked in 4 countries of the TB REP project together with the National TB program to analyze the patient's pathway. And they will acquaint us with all the peculiarities of data collection, methodologies. They will present the lessons learned. And most importantly, I would like to invite Shahnoza Ramova, who represents Tajikistan, the National TB program, to share her country experience, the experience of Tajikistan. Now, the colleagues, the floor is yours. Thank you, Liliana. Dear colleagues, good day. First and foremost, I would like to thank all the organizers for bringing us together. I would like to thank our colleagues from the WHO Bureau, from the PASS Center for organizing this webinar, which is really topical and interesting. As the work was performed by a team, we will present as a team, and this presentation will be dedicated to the analysis of the patient's pathway in 4 countries, Eastern European, Central Asian countries. I will start the presentation and my colleagues will continue. Next slide, please. So the analysis of the patient's pathway. It was a new exercise for our country. And here you see in the publications, the references. We use them as the foundation. And we developed the methodology of the analysis and the procedures of the analysis. Next slide, please. This is the continuation of the references, which served as a foundation for the performed analysis. So what was the goal of the performed analysis? It was to identify the potential gaps in the organization of healthcare, including the presentation, the primary health-seeking behavior, diagnosis and treatment, everything faced by a patient when seeking medical care in case of suspected TB. So what was the methodology of the analysis? Based on the publications we used to inform our work, so we performed a review of the quantitative data collected within countries or from countries. We used and we developed a methodology using quantitative data, and we also added a qualitative component, a qualitative research. We performed interviews with physicians and patients to identify the key problems faced by people when seeking healthcare and providing care. We used subnational level for quantitative data. As for qualitative component, we use selective sampling by regions. And the essence was to ensure coverage of all the regions of the country. We developed a data collection method for the quantitative component and qualitative component. For the qualitative component, we performed interviews with physicians and patients from primary healthcare, and separate interviews with the patients. As for the data analysis and the estimations preparation, based on the results of that work, we came up with recommendations and visualization of the outcomes of the analysis. So what were the stages of the analysis? So we started with the development of the data collection tool. And the data collection tool was an Excel file where we enter data on healthcare facilities, epidemiological data, data on presentation, and there was a separate sheet on all the indicators. Following the development of data collection instrument, we identified the sources of data and proceeded to data collection. And we then developed the questionnaires to interview TB physicians, primary healthcare physicians, and TB patients. We performed interviews then with TB physicians, family physicians, TB patients, and performed the analysis of quantitative and qualitative data. And then we performed the estimation of all the indicators and the visualization of the analysis to get the clear picture of patients' pathway. Here you see the data collection tool for quantitative data. You see some geographic data by cities or regions, the population, the size of the population, and the data are listed before. The diagnostic capacity of the facility, the data on the number of presenting patients, So you see what kinds of data are included. All the data were collected for 2019, as the analysis was started in 2020. So we analyzed the data for 2019, and the data were collected in 2019. So we also included some corrections during the analysis. And I would like to say that interviews were performed online. For the quantitative data, what were the sources? Those were the data gathered with the support from the national TB coordinators, official sources from the Ministry of Health of the countries, data provided by the services of statistics, to which we gained access, and we also used some additional sources for the analysis. At that, I would like to pass the mic to Mikhail Volek. Thank you. Thank you very much, Armen. Good day once again, dear colleagues. Today is a very good opportunity, and today we have a very good company. It's a good reason to put on a tie, but hopefully we will get back to old norm, and we will have at least a certain number of offline meetings. Continuing what Armen has started, I joined the team a bit later. I joined a very good research team, but I enjoyed our joint work immensely. It was something new, and my task will be to tell about the methodology and how it was modified a bit. Next slide, please. Because ideally, everything looks perfect. This is the standard visualization based on the founders of this methodology. By the way, we used the instrument based on internet resources. It's a very powerful statistical instrument and visualization tableau. And it's open component tableau public, but it's not as easy as it might seem. And if we have a closer look at the methodology, you will see how much preliminary work should have been conducted and how much data should have been gathered. And even though that this information is open and accessible, and we took the data for 2019, long before COVID-19, but nevertheless, it required lots of efforts, and the data collection efforts were even immense. And despite the fact that the data are available, it's very difficult to gather them and analyze here and now. Therefore, we should have covered all the stages, but if you pay attention to the patient's pathway analysis, you will see that there are lots of levels, there are lots of services providers involved, and I would like to explain the differences of the methodology we used from the initial model because of the context existing in the countries. For example, we have not mentioned yet the countries where we work. It was Kazakhstan, the Kyrgyz Republic, Tajikistan, and Belarus. And in Belarus, the process is still continued. We are gathering the data, and results will be presented, but a bit later. So in order for us to calculate the indicators used within the methodology, we first and foremost need the data on health-seeking behavior, on presentation. We take into account the key typical symptoms, which indicate probable TB diagnosis or acute respiratory infection or respiratory infection. And we need to learn about the distribution of their flows, how people present in various facilities of the primary health level, secondary level, or tertiary level. Therefore, we have several levels, and the zero level or pre-physician level, it exists, but we didn't take it into account because there are no officially recorded data. But it might be something to take into consideration because some healthcare is provided at this level, and maybe if a patient develops symptoms typical of tuberculosis, they might require this pre-physician care, and it shouldn't be ruled out. But we take into account the public sector and private sector, formal and informal, as provided by the methodology. And for us, it's very important to learn the number of healthcare facilities of various levels, which are sufficiently equipped to perform diagnosis of tuberculosis and to initiate treatment of patients on the day of presentation. It's very important, and it changes the paradigm of what we are looking at from the standpoint of people-centered approach. It's the provision of care in the place and at a time convenient for people. It's a very important difference from our methodology, and it should be taken into account when we come to interpretation of the findings. And we also wanted to get the disaggregated data by territories just to learn what happens in this or that geographical point. After that, when we get all the data, you see how the indicators are calculated. We assess diagnostic coverage. We assess the entire number of healthcare facilities and see how many of them are sufficiently equipped to perform diagnosis. And so this is the ratio. It's the diagnostic coverage within this methodology. And the same
имеют набор противотуберкулезных препаратов, которые могут быть назначены, да, и предоставлены.
The same for treatment. There are a number of facilities with the capacity to perform treatment, having drugs available to the overall number of healthcare facilities. Yeah, so it's the number of properly equipped to start treatment to the overall number of healthcare facilities. So we need to assess these two ratios, and then we calculate the percentage of population presenting to the facility of this particular level and by the diagnostic coverage. And then we have the indicator of accessibility. Then we get them all together and we get the final data. So if we look at the level of healthcare provision, then it was necessary for us to stratify everything by levels of healthcare provision. And we didn't include the private facilities and other types of facilities, but we took into account primary healthcare facilities and the peculiarity of our TB services is that after the primary healthcare, people are referred to the secondary level facilities. Therefore, we included anti-TB facilities, TB hospitals, TB dispensaries, regional, district, and tertiary level facilities such as Republican or national TB centers. And if we have a look at everything from the standpoint of a patient, then you should click several times so that we have all the data presented here. Here you see highlighted the facility or the providers, the service providers, healthcare workers, to whom a person might turn to for care and whom we could take into account in our analysis. At the same time, we see that there are lots of providers outside of our attention, and we need to introduce some correction. even with the number we receive, we understand that we don't take everything into the account, and therefore the indicator of accessibility might be even lower, because we don't know what happens in these not highlighted facilities, and we don't know whether they're better equipped for primary diagnosis. Even though we see that some interesting thing in pharmacies, we know that people with acute respiratory infection symptoms might turn to a pharmacy. For example, a physician who is a friend or acquaintance is another source, and some traditional healers, they exist, and some people use their services. We also have the district TB dispensary, even though it should be highlighted and it should be taken into account, and primary clinics, diagnostic centers, primary diagnostic centers, and other types of private facilities who provide services. So in our case, in order to calculate the number of healthcare facilities properly equipped to perform diagnostic of TB, we took into account the primary healthcare facilities, which had the following: the ability to perform smear microscopy, to perform X-ray, or rapid molecular genetic tests, for example, GeneX. In addition to that, we tried to take into account the capacity to perform X-ray diagnosis using mobile X-ray devices, given that those mobile devices were temporarily assigned to those facilities. But we see certain assumptions and limitations at this stage. X-ray diagnosis is not logical. It has low specificity for TB, and therefore perhaps we mostly focus here on screening. But nevertheless, we included X-ray to assess this screening capacity at the level of primary healthcare. For second and third level facilities, we believe that they being properly equipped if the entire set of diagnostic services were available. And we believe that all second and third level facilities have that capacity. We also assess the coverage with the treatment services, the capacity to initiate treatment on the day of presentation, the availability of TB physicians, and cabinets, and the availability of anti-TB drugs. And we also believe that by definition, second and third level facilities were sufficiently equipped to perform treatment initiation on the day of presentation, just by definition. And I would like to repeat the assumptions. We didn't take into account the pre-physician level. We didn't take into account the primary private sector. And there was a difficulty that we failed to disaggregate data by levels of the care provisions. Unfortunately, it is not possible, or it is possible, but it requires additional time and effort and staff. But it is important for evaluation. Therefore, we have to make a decision, either that it's impossible to perform such disaggregation, or use some modeling based on the peculiarities of our work. We followed modeling on two scenarios. First, we assume that the majority of people with symptoms of acute respiratory infection seek care and present at primary healthcare facilities, and a small percentage of people can present at anti-TB facilities. And like 10% of people can directly go to second or third level facilities, anti-TB facilities, to receive care at the day of presentation. We assumed that these two scenarios describe the overall picture of people's behavior, and that allowed us to calculate the indicators for coverage and accessibility or availability of diagnosis and treatment. Thus, if you visualize everything, you will see that. So this is what the modeling was based on. 90 to 99% of people go to private healthcare facilities, and the 1 to 10 people go directly to secondary or tertiary level facilities. And here I would like to pass the mic to Naira to tell about the peculiarities to tell about the peculiarities of the qualitative research, and because it has really improved the quality and the value of the study. When we started the research, it was not part of the book published, but we saw high demand for data, so that there is sufficient evidence based for people-centered care, because we want to avoid situation when people are referred to somewhere where there is no capacity to perform diagnosis and treatment. Naira, please, the mic is yours. Naira, please unmute yourself. A good day, dear colleagues. I would like to thank everyone in advance. I would like to thank all the people who work together. I would like to thank all the people who express interest to our methodology and to the results we gave. I will continue speaking about qualitative research we used in our methodology.
Just like Michael has said, this methodology adds to that qualitative data that we had implemented. Qualitative study implied collection of the information with the use of previously designed questionnaire on the main directions of the TB care. And you can see the structure of our questionnaire that included some general data, questions related to detection and screening, diagnosis, treatment, the level of awareness and satisfaction of patients, social and psychological support of our patients, patients' rights, issues related to stigma and discrimination, and general satisfaction with the health system performance. I would like to say that the second part of our study included discussions in focus groups. Within our national program, we selected the most interesting and topical questions, and we selected 3 of them. Number 1 is factors which get on the way to early referral or self-referral of patients to the healthcare facilities and early detection, diagnosis of treatment. Question number 2 was related to stigma and tuberculosis. Stigma in families of our patients and refusal to self-refer themselves to the TB services. Question number 3 was about the impact of COVID-19 pandemic. In the focus groups, we had very interesting discussions, and I would like to say that our patients who participated in focus groups were very open. They kindly answered all our questions, and it was very interesting to work with them. I would like to say that this qualitative study was very labor-consuming, and I would like to thank my colleagues who were able to implement this study successfully. in order to identify the problems from various points of views. The researchers and the teams of the national consultants selected the groups of physicians from the specialized TB facilities, as well as physicians from the primary healthcare. We had focus groups with the patients who self-referred themselves to the healthcare facilities, included due to symptoms suggestive of tuberculosis. I would like to say that during the collection of this information and during the interviews, we had some challenges due to the fact that during COVID, we could not have face-to-face meetings, and we had interviews at the national level with translation, which took some extra time. Participation of the international consultants in this process was quite limited. Consultants could be the observers, and most of the work was done by the national team. We also had some problems related to connectivity and internet connection. Later on, I will give the floor to Armen and Michael, but I would like to say that we analyzed the data, and on the basis of this analysis, we got some interesting results. They can be shared with the countries for improvement of their programs. We would like to thank the participants of this survey and facilitators of the survey. Now, I would like to give the floor to my colleagues, Armen and Mikhail. Thank you very much, Nair. I would like to thank our colleagues from the WHO and from the PAS Center.
Николаевска, с кем мы начали этот проект.
As well as people who were at the very beginning of this project and who supported the idea of this analysis. Thank you very much for this work, because this analysis is a very interesting instrument, especially for the TB service and for the healthcare system of our countries in general. Also, I would like to thank our country counterparts from Kazakhstan, Kyrgyzstan, Tajikistan, and Belarus for your support and the implementation of all these activities that were needed for this analysis. Also, I would like to thank the PAS Center for your support and for the analysis of our results. And of course, the most interesting part is the results, and we decided that it would be good to present the results in relation to the interested countries. And now I would like to give the floor to Shahnoza, who will present the results for Tajikistan. While we're waiting for Shahnoza, I would like to remind everybody that you have an opportunity to ask your questions in the Q&A tool. We will try to answer your questions right away. Later on, at the end of the presentations, we'll discuss your questions in more details.
Добрый день, уважаемые коллеги. Надеюсь, меня...
Good afternoon, dear colleagues. I hope you can hear me very well.
Если вы закончили, Андрей, я могу начинать? Или
Да,
еще
пожалуйста,
нет?
будьте любезны. Я просто заполнил время, пока вы готовились. Спасибо.
Спасибо большое. У меня небольшие технические неполадки были.
I had some technical hiccups at the beginning, but hopefully I was able to take care of them. Dear colleagues and participants of this webinar, I would like to welcome all of you. As you can see, we had an opportunity to find some preliminary results presented by our colleagues and to find out about the experience of other countries. This experience can be used in our respective countries. Now I would like to share the analysis or the results of the analysis of patient's pathway in Tajikistan.
Послужило то, что на этот период Таджикистан готовил национальную противотуберкулезную программу по защите населения от туберкулеза на 2021-2025.
In order for Tajikistan to participate in this analysis, we had an approved new national program for protection of the population of Tajikistan for 2021 and 2025. We also developed the applications to the Global Fund, and during the discussion of these documents, we could see that we need to achieve very important targets of the national program. And of course, in order to do it successfully, we needed to generate sound evidence and to improve our approaches, making sure that our work is patient-centered. It became obvious for us that in order to generate this information, we needed to implement the analysis of patient's pathway. On this slide, you can see the epidemiological situation on tuberculosis in Tajikistan. You can see the estimates of the World Health Organization and the data of the National TB Control Center, the Departments of Statistics. Here you can see the data for incidence and notification of new cases in Tajikistan between 2000 and 2019. As you can see, the incidence rates are quite high.
Наблюдается как бы заболеваемость в европейском регионе. Также здесь не исключились, как бы включены информация по ВИЧ.
Also, you can see the data for TB mortality among HIV-negative people. This data was reported between 2000 and 2019. On the right-hand side, you can see treatment success among new TB cases between 2009 and 2019. This is the cohort of drug-susceptible tuberculosis. The major decrease in treatment success was reported in 2012 when we started enrolling patients with drug-resistant tuberculosis. But as you can see, over time, we were able to increase the effectiveness of treatment in the group of drug-susceptible patients. Also, you can see the results for 2018 for treatment outcomes among patients with drug-resistant tuberculosis. At present, we increase treatment success among patients with drug-resistant tuberculosis. On the slide, you can see the cascade of TB care in Tajikistan. And based on the estimates, in our country, we are able to ensure 100% coverage of people with suspected tuberculosis. 75% of patients are being notified. That includes new and relapses. 64% of these patients are covered by molecular genetic tests with the use of Gene Expert. Of those 64%, 49% had bacteriological confirmation of their diagnosis, and 45% of them start on treatment. 38% are in the follow-up group. In blue, you can see, or in green, you can see TB patients. In yellow, you see MDR TB patients, and dark green, you can see patients with extensively drug-resistant tuberculosis. You can also see some numbers in tables. In table number 1, you can see the estimated targets for 2019. So according to the WHO estimates, the total number of TB cases was 7,700, and 5,755 patients, these are new cases and relapses, were notified. Gene Expert coverage was ensured in almost 5,000 patients. In the next table, you can see the data for confirmed TB cases with the breakdown by case of susceptible tuberculosis, MDR-TB, and XDR-TB. And you can see that 49% of detected cases had bacteriological confirmation of their diagnosis. Also, you can see the proportion of patients who start on treatment. At present, our country does everything possible in order to ensure proper coverage with treatment. However, we still have some questions who get lost on the way between diagnosis and treatment.
You see treatment success for susceptible cases and for resistant cases. You see it's 64 resistant and 62 for XDR. So the average is 38% success rate. So what are the major attrition? So the biggest losses are between the first symptoms and the early detection stages. 25% are lost. So we know how many patients are lost from primary presentation to the treatment initiation, but unfortunately the precise percentage was calculated by the World Organizations, 25%. So 25% of patients are lost after the presentation until the treatment initiation within the healthcare system. They are either not detected or not properly covered. At the laboratory confirmation stage, and I should say that 67.2% of TB patients, pulmonary TB patients, have the diagnosis confirmed by a bacteriological methods. And so there are also losses during the treatment of patients with multi-drug and extensively drug-resistant tuberculosis. So what is the key issue? How available are the diagnostic services and treatment services, including MDR-TB, for the population of the Tajik Republic, from the standpoint of the patient-centered model? In order to answer this question, we made some preliminary conclusions. So what was the goal of the patient's pathway analysis in Tajikistan? It was to identify the potential problems and barriers to uninterrupted chain of service, organization, and provision, and the provision of primary healthcare services and anti-TB services in order to improve outcomes of prevention, TB detection, and treatment. A few words about the methodology. As in other countries, to analyze the patient's pathway, we plan to perform an express analysis on the availability of TB services, on TB diagnosis and treatment over their presentation. And also we wanted to gain additional data gleaned from the interviews with physicians and patients in order to learn about key drawbacks of anti-TB care provision. On the right, you can see the diagram used during the analysis. Here you see the clear and short geographic coverage performed at the national and subnational levels. As for the data collection method, we used special checklist. It was developed by the researchers team. Our national consultants used that checklist to collect proper data. We also used a special data collection tool, the guide for focus group discussions. We use two methods based on quantitative and qualitative data. Overall, we performed interviews with 14 physicians. We also interviewed 20 primary healthcare physicians and 13 patients. We delivered 7 focus groups, which were comprised from 5 to 10 people. At some points, 10 people participated in the focus group discussion. At other times, 5 patients, for example, participated in focus group discussions. What are the key findings of the quantitative evaluation? The zero level was not taken into account. I can continue. We can move to the next slide. Because here you see what we... Shahnoza, if you like, I can support you. I can continue. So here you see the results we received for Tajikistan. Please pay attention to the fact that it's the data for 2019. Some things might have changed, but we assessed the situation as of 2019. Diagnostic coverage, the ratio of the facilities properly equipped to perform diagnosis at the primary health level to the overall number of facilities varies from 2 to 8%. overall. For the country, it's 2%, and it's a bit higher in Dushanbe, 8%, and 100% at second or third level. And some facilities lacked. You might remember that we initially assumed the availability of the whole set of diagnostic measures and services. And here you see the treatment coverage. It is very similar to that of diagnostic coverage. It is low, unfortunately, but it is high in Dushanbe. And it might be associated to the fact that outpatient care departments are better equipped in the citizens than in regions. And if we use the first scenario, you remember, within which 99% of primary presentations happen at the level of primary health care, you see that the availability of diagnosis varies from 2 to 9%, and treatment availability varies from 2 to 7%. What does it mean? It means that a probability that a person turns to public facilities with symptoms suggestive of TB. So a person has a disease and seeks care at the facilities, at the place of residence. The probability of diagnosis is 3%. So 1 in 30 people will be diagnosed. And it's a bit higher in the capital of the country, and it's lower in other regions. For example, heart-lung region, it's about 2%. If we believe that up to 10% of people go directly to the secondary level facilities, anti-TB hospitals, then you will see that the diagnosis availability is high, but it still remains insufficient. It remains low, and it's not higher than 70% in Dushanbe, let alone other regions. This is a sign of low availability of diagnostic services. We are speaking about the availability of diagnosis at the time of presentation. So if a person develops symptoms and seeks medical care, and on that day he or she should get diagnosis. We understand that there are certain assumptions, but nevertheless, this type of modeling helps to identify the vector, the direction, and come up with the minimum and maximums which might be used to guide the decisions. And this methodology helps to arrange the evaluations. We always choose the best score. So we receive similar scores for the rest of the countries within our analysis. Shahnoza, are you ready to continue? Thank you, Mikhail, for stepping in. I'm suffering from this allergic cough. So what are the results of the qualitative analysis? So we performed interviews with physicians. As I have previously mentioned, we invited TB physicians and primary healthcare doctors, and we used checklists, and we saw that the poor coordination of the anti-TB services and the family medicine systems was ranked the first. And in Tajikistan, we really have some difficulties in the integration process. But when we performed the analysis and interviewed the physicians, they all confirmed the availability of the problem. But the second issue was a lack of specialized healthcare facilities in remote areas and in rural areas, where we have a fellow or a nurse, but there is no capacity for smear microscopy or X-ray tests. You should say that all those tests and X-ray are available only at the district level. And in smaller municipalities, we don't have such a capacity. And the second or the next problem was lack of staff and low motivation. We know that the physicians, the family physicians or family nurse, they receive certain amount, but they in charge of implementation of 24 state programs. So there is huge amount of work and the salary is low. And therefore, we need to introduce additional incentives for these specialists. For example, if you calculate, if we take into account all the responses we received from the respondents, they all agree that they all need some additional financial stimuli. And another problem is poor work with people who had TB diagnosis in the past or who had already experienced going through the services. They all complained of long process. They had to visit the facility several times, and therefore, from rural areas, they go directly to the district level or they go directly to the national center, skipping the intermediate stages. So they skip this primary healthcare level. They skip the district primary healthcare facility. They go directly to the TB services. Self-treatment or late presentation is a separate issue. When we reviewed the TB patients, many said that they would go directly to the pharmacy and would self-medicate using symptomatic treatment, asking a person at the drugstore recommend something for very simple. So people use even traditional medicine for self-medication. Chronic diseases is another aspect. Many patients believe that productive carb and other TB systems were related to the chronic diseases such as diabetes mellitus or other lung diseases, including asthma, and therefore they continued treating with the drugs prescribed previously. Another issue is labor migration. It's an important factor. Migrants, for example, outside the country, they were waiting for their job to be finished to return and to seek medical care, or they would seek medical care, but because of the not free of charge nature, they wouldn't continue. They either won't undergo proper diagnosis or they would interrupt treatment, and therefore 14-15% of people of all the TB cases are labor migrants.
Отражена. Следующее это отдельно это позднее выявление TB.
Next one is late detection of tuberculosis during postpartum period. During our focus group discussions, some participants told us that they were sure that this kind of manifestations were related to some gynecological problems, and their family physicians or gynecologists indicated treatment for complications after the delivery of their babies. And in some remote areas, it is quite difficult to get proper consultations of the TB experts in such cases. Despite the current limitations of the methodology, it gives a lot of very important information for better understanding of the situation. And also, it provides qualitative and quantitative assessment of the problem related to accessibility of the TB service. The system of TB care delivery in Tajikistan is highly centralized, and the availability of services for diagnosis and treatment in the specialized facilities is in contrast with their low availability in the primary health care facilities. The majority of the TB centers are located at the regional and central levels, while at the level of the districts, we have primary healthcare facilities. So the diagnosis and initiation of tuberculosis on the day of self-referral is not available for the majority of the population of the country, especially in some remote areas. In order to have proper diagnosis and treatment, our patients have to visit the regional centers where they can get quality services and to get some additional referrals for specific examinations. As for the next steps, it should be noted that our consultants, Dr. Volik and the National TB Control Program have started the development of the plan of our next steps. So we plan to increase the availability of the diagnostic services for tuberculosis at the level of the primary health care for people with symptoms and signs suggestive of tuberculosis. We also need to increase the availability of TB services at the primary health care. We also need to improve the system of collection, analysis, and the use of data related to diagnosis and treatment of tuberculosis in order to assess the situation at the national, regional, and local levels. On behalf of the Regional TB Control Center of Tajikistan, I would like to thank the regional project for TB control in Eastern Europe and Central Asia, that is TB RAP 2. Also, we would like to thank the Global Fund for their financial support and for an opportunity to implement this kind of analysis. Also, we would like to thank the PAS Center and our dear consultants, Naira Khachaturian, Armen Ayropetyan, Svetlana Nikolaescu, Mikhail Volik, Liliana Karaulan. And we also thank all those who participated in this analysis. These are our respondents, including our patients who participated in the work of our focus groups, participated in the interviews. We also thank family physicians and the internal disease physicians who shared their opinion and participated in the interviews. Should you have any questions, please feel free to ask them. Thank you.
своей презентации пропустила Всемирную организацию здравоохранения.
And my apologies. I also want to thank the World Health Organization and Dr. Andrei Dada, who is with us today. And I thank other colleagues from the WHO as well. Thank you very much, Shahnoza. Mikhail, Armen, Naira, do you have any comments or additions? Please share them now, and then we'll give an opportunity to our participants to ask their questions. Well, we went beyond the schedule of our webinar, and I'll try to be very brief. To sum up, I would like to say that the analysis was very interesting, and the results of this analysis are also very interesting. In fact, it was like a cold shower for us. However, we saw some good results in Tajikistan, and we see that the effectiveness of treatment is quite high. However, we need to make sure that these results are sustainable and that services provided to the patients in the country are patient-centered. We are experiencing that stress test of COVID-19 pandemic, and of course our priorities shifted. However, we also need to remember to maintain the high quality of TB service in our countries. Thank you very much, Shahnoza, for the presentation of your results and for mentioning the next steps aimed at improving availability of diagnosis and treatment. I think that you need to focus on these indicators and to think of what needs to be done when you expand your model of patient-centered approach. We don't have very many tools for that. We have the quantitative assessment tool, which is very useful. And we also analyze the cascade of care, and we can see the losses from one stage of cascade to another. It varies in different areas and at different time periods, but we can see that in certain years, only 39% of patients successfully completed their course of treatment. And of course, it is not sufficient if we want to hold the situation and to achieve the world free of tuberculosis. And of course, the lack of services tells on the burden of the disease and on the burden of this disease in our patients. Not all countries implemented this patient cost survey to assess the burden of tuberculosis on patients. But when they implement it, they will see that the burden that lays on the shoulders of their patients is very high. Speaking of the methodology, I believe that we need to think about the use of these indicators in the future and whether they can be used in our practice. And of course, this this tool of rapid assessment helps us to assess the situation over time. We allowed all methods of diagnosis, including X-ray diagnosis. However, if we take the algorithms used in the countries, that is the use of patients with the rapid diagnostic tools such as Gene Experts, the results of diagnostic availability will be even lower. So how can we improve the situation? The PASS Center provides the entire range of technical assistance, including the plans of joint actions and strategic plans. It also highlights the next steps. And of course, it will be very interesting to discuss these activities during the discussions. Thank you very much again for your attention and for quality work of all my colleagues. Thank you very much.
Что было замечено, которое немаловажно во время фокус-групп discussion, когда мы
I
задаем
would like to say that during the focus groups, when we ask patients some questions, it was very important for us to note their answers.
Они сказали, оценили роль новейшего, то есть в виде контролируемого лечения.
Many patients spoke highly about VOT.
И проведение вот таких фокус-групп discussion, типа качественные.
And this kind of focus group discussions gave us an opportunity to learn more about patients' needs. And so that's all I wanted to add.
Andrei, dear colleagues, perhaps we can take 1 to 2 answers, questions, and then proceed. So we have raised hands. I see Victor's hand raised. Victor, please unmute yourself, ask your question. I also see that Q&A, perhaps most of the questions have been answered. Please have a look. If your question haven't been answered, please raise your hand. We will. Victor, please unmute yourself.
Victor? Окей. Что-то у Виктора. Алишер, пожалуйста, да.
Alishar, then please go on. Good day, dear colleagues. Thank you very much. Unfortunately, I joined you late at the very end, but my question is as follows. Would it be possible to get the report? I've got an idea. All the data you presented, they are like precise facts that we have quite serious issues. And therefore, we in Tajikistan need to start tackling these issues. And right now, we are discussing a package of state-guaranteed services. And perhaps we could use your data for building the case, for advocacy, for us to use as a starting point to bring attention to the issue, to add maybe the services to the package of state-provided free of charge services. So for us, it would be really useful to advance our goals when talking to the Ministry of Finance. Alishar, we are at the final stage, and the national TB program will gladly share all the data with all the partners and counterparts, and it will discuss all the data we got with you and the next steps. What Shahnoza presented on the slides is only a small part of what could be done and should be done to improve the access to all the aspects of the TB care cascade. So soon be available.
Okay, спасибо.
So once again, if we have a look at the questions, we'll see that this methodology was used in 4 countries. Today, you heard the example of Tajikistan, where the report is almost finalized, almost ready. The final tunings are being performed. As for the rest of the countries, the national TB programs are holders of the information, and we encourage, we, meaning the World Health Organization and the PASS Center, we encourage entities to publish all the reports to make the findings available to a wider scale of counterparts. As for severe cases with advanced TB in focus groups, Armen, Naira, thank you for answering the question. National TB program selected patients during the qualitative part of the research, and outpatients were also invited. We had questions pertaining to primary healthcare network, whether the percentage of refusals, what was the interview exception rate, and Armen and Naira responded the question in writing. Everything will be described in detail in the reports. A very interesting comment about the support provided to the patients, the social support for the patients, and how it affects the availability of TB diagnosis and treatment. I don't know what is the direct correlation between the carrots and the availability. I believe that the support should be provided. When a person seeks medical care and receives medical care, if they need, they should receive social support. So it's not only a package of health services, it should be aligned with the social support as well. Another important document one of the deliverers of the project was community-based services for tuberculosis. Describing the set of services that could be provided at the community level and those services might be provided by communities engaged in various areas of social support. NGOs might be providing some social support and services. And this is an important factor facilitating good outcomes and proper recovery of patients. I don't understand quite what is the question, what stage is a mental and differentiated approach is mentioned. Don't see a raised hand. Andrei, I think that we have covered all the questions. But dear colleagues, if your particular question hasn't been answered, we remain online. I see a raised hand. TB Rep 2. Please unmute yourself. Introduce yourself and please ask your question. Dear colleague, with a raised hand, TB Rep 2, we don't know who is under that name. We see your raised hand. Please unmute yourself. I guess there is some technical difficulty.
Еще раз
Я предлагаю, да,
спасибо.
до благодарности, Андрей.
Да,
До благодарности.
квартет.
Да, нам
So
хочется
we come to the acknowledgement, but we would like to receive some feedback from the participants. We are describing a new instrument which has been at this stage introduced only in a small number of countries. This instrument might contribute to the evidence base which may be used to inform work on improving care provision. Let's use the second survey to see what do our colleagues think about it and what are the gaps.
Действительно. Итак, если мы сделаем небольшое такое оглавление, то у нас
So,
была
dear colleagues,
теорией
we had a lecture with theory,
применение данной теории с адаптированной
then we
регионной методологией было
moved to the practical use of the adapted theory.
большое спасибо.
Thank you very much to our members of the quartet.
Кто-то из вас в странах данную техническую данный
Maybe
посчитает полезной. Мы очень на это
some of you will find this methodology useful. You might require some technical support. Therefore, we would like to ask you to look at these questions and help us properly plan our collaboration and what types of support we need to provide you to analyze the patient's pathway.
Интерпретации данного анализа таким образом, чтобы оно было направлено на пациента, на человека.
To improve the patient-centeredness in your countries. Please look through the questions and answer the questions, whether you have performed the patient's pathways analysis in your countries. Did you revise the model of TB care provision? So the conventional model, whether the model was revised, yes or no, including whether the needs were assessed, the resource needed whether were assessed, the staff and the funds. We see that 67% replied in the negative, but the absolute numbers are not quite big.
Небольшой объем выборки, но тем не менее, коллеги, будьте любезны, не скупитесь на ответы. Вас
Dear colleagues, please.
Мы очень хотели знать ваше мнение. Нужно
We have 45 participants. We would like to know from you whether you need or don't need some technical support to perform the analysis of patient's pathway and to revise models of care provision to make them more patient or people-centered. It will help us to plan our work. And the question number 3, if neither the analysis nor remodeling have been done, then this question number 3 helps you to identify when this support might be needed in the short term, medium term, or long term. And then we will be able to provide. Okay, we see first quarter, mid 2022, late 2022, or 2023. We see that partners are not quite willing or not quite planning providing this support. Therefore, we, the PASS Center and the World Health Organization, will try to advocate for the use of this methodology. And we will also advocate adapting the models following the analysis performed. So for us, it will be very important to have some support provided by the partners. perform the analysis and to adapt models of care provision. And the final question, what types of support might be needed? Either analysis, or other types. Yes, some might need capacity building support, and we mean trainings, workshops, seminars, and technical support to perform the patient's pathway analysis. It might be combined with the answer number 1, recommendations on PPA analysis. 14 people responded. It's a bit low from out of 45. We expected more responses, but nevertheless, 14 people have a clear-cut plan. Lilian and colleagues, please take it into consideration that starting next year we'll need to start a more precise planning of how to provide care to this respondents. So we have okay, good. And the final question helped us to glean the answer on what type of support might be needed. Thank you very much. At that, I would like to close the survey. Dear colleagues, do you see the responses? So these are the polls results.
Ну что, так сказать, мы что сделали? Мы вам
So what have we done? We have provided you with a theory. We shared some practical examples. We described how everything was performed at the country level. We promised to come back and we will disseminate other reports and we will share experience of other countries. And element number 3, we've looked into who might need support, what type of support, and starting next year we will try working with the national programs. Lilian, will you have some additional comments? If not, then we might switch to the final part. Please, Andrei, go on. I thought you will start, but then I will proceed. The poll has shown that the countries are interested in this tool, so it means that there is interest in enriching the evidence base. It was one of the instruments used within the TB-REP project, and this will add on to what we know in many countries based on the needs assessment, rapid molecular genetic tests, district levels, what we've seen within the barriers assessment, stigma and discrimination, human rights violation.
We also receive the information from communities, from monitoring implemented with the engagement of communities. Our general goal is provide assistance to all those who need it in order to improve the model of care delivery, making sure that it is patient-oriented or people-oriented. In order to support the countries in this work, we have very good experts who generated a lot of experience in this field, experts in the analysis and evaluation. They can provide their assistance to the countries. So should you need their assistance, please let us know. You can write directly to us or to Andrei, and we are always open for communication. Thank you very much. Andrei, the floor is yours. I would like to add a couple of comments to add. This project has been focused on remodeling of TB care with provision of social and other types of support in the healthcare systems. This work was done on improvement of finances and the quality of services. This project is coming to an end, and PASS Center has a plan to have a conference at the end of this month, and I kindly ask my colleagues from the PASS Center to share your plans with our audience. I hope to meet all of you on the 21st and 22nd of December. We sent our invitations to all our partners, and we hope we did not forget anybody. This is a 2-day conference, 4 hours each day. I'm afraid to set up the exact time now, but if I'm not mistaken, we will start at 9 o'clock in the morning, Central European time. So we kindly ask our colleagues to register for the conference, and I'm sure these 2 days of the conference will be very interesting. We'll touch upon the topic of our today's meeting and some other topics as well. We'll talk about various tasks of the project, and we'll give an overview of them. Also, I would like to say that if you did not receive the invitation from us, please get in touch with us. It means that you are not in our distribution list, and we will make sure that you are included. This way, you will continue receiving our notifications and updates. Since we're coming to the end of the project, we can say now that we were able to generate a lot of expertise and experience, and the WHO will be able to ensure the continuity of the work initiated in the countries through the WHO platform. So this is the end of this project, but not the end of our activities. We only start a new chapter in the book, the chapter that will have very clear methodology, very extensive expertise based on the experience generated in the countries of our project. We can see that Turkmenistan is also adapting the model of people-centered care. So please feel free to contact us, and we'll be glad to use our developments and the experience gained in the TB-RAP project. So we have come to the end of our webinar. On my behalf, I would like to thank our colleagues from PASS, and I thank you on behalf of the World Health Organization. We also thank the core group of 4, and I hope that you colleagues will remain available for technical assistance to the countries later on in the activities that will be organized by the World Health Organization. Perhaps Liliana would like to say some words as well. Yes, I would like to thank all of you, Nair, Armen, Mikhail. And I also want to thank our colleagues from the countries who collaborated with you. We know that it was a real teamwork that also includes the teams of the national TB control programs. I would like to wish all of you to wisely use the results of the analysis and jointly improve the models of care. We went beyond the schedule, and I thank you for your patience and for your dedication. I would like to wish all of you good health, and we'll be looking forward to meeting you on the 21st of December, where we will discuss all these topics more broadly. Thank you and goodbye.